Now, let us talk about my approach to patient with relapsed multiple myeloma. The last ASH meeting in 2014, the ASPIRE trial results were announced. And there are a number of other trials in the pipeline which I'll talk about in a moment. Now, let us talk about what did the ASPIRE trial do. Carfilzomib is already approved for treatment of relapsed multiple myeloma. So the ASPIRE trial looked at whether carfilzomib could be added to lenalidomide and dexamethasone, and does it add to the outcome of the patient. So patients who had 1 to 3 lines of prior therapy only, those who have lenalidomide naive or they were not progressing on lenalidomide, or patients who are proteasome naive, or those who are not proteasome refractory. So these are the patients who enrolled on this clinical trial, and the patients were randomized to receive lenalidomide and dexamethasone, or lenalidomide, dexamethasone, and carfilzomib. And the results showed that the patients who were randomized to lenalidomide, dexamethasone, and carfilzomib had a much better progression-free survival. And there was a trend for improvement in overall survival. The reason I'm saying it is a trend for improvement of overall survival is because the study, had an independent data monitoring review committee, and there were stop rules that if there was a survival advantage to 0.005 level, then the study would have been stopped. The study was only stopped for improvement in progression-free survival, not that the survival was substantially better in the arm. But if you look at the data, there is a trend for improvement of survival. So here, for the first time, in a relapsed myeloma, even a first relapsed myeloma patient who is not refractory to immunomodulatory molecule, who is not refractory to proteasome inhibitor, how would you approach? Before, we would have said use lenalidomide and dexamethasone, or use carfilzomib and dexamethasone, use pomalidomide and dexamethasone, or any of those would all be an option. But now the ASPIRE trial set the benchmark that perhaps we should consider using lenalidomide, dexamethasone, and a proteasome inhibitor, carfilzomib, looking at the ASPIRE trial. Now, ASPIRE's trial results came out in ASH, but we also know that there are several other trials which have also been positive and which will come out perhaps in the ASCO of 2015. So one is ELOQUENT-2 trial. The ELOQUENT-2 trial is lenalidomide and dexamethasone with or without elotuzumab in a similar patient population similar to ASPIRE trial, and this also met the criteria. The study was positive for progression-free survival, and we are all anxious to look at the results of that coming out in the ASCO. Then we also heard a news splash from Millennium saying that the Tourmaline-1 trial, which was in a relapsed myeloma patient in a similar patient population, lenalidomide, dexamethasone with or without ixazomib, the patient who were randomized to lenalidomide, dexamethasone, ixazomib had a better progression-free survival. So you have 3 studies showing that 3 drugs are better. Now, in the same ASH meeting, there were 2 other trials which were reported with pomalidomide. So pomalidomide, dexamethasone was compared with pomalidomide, cyclophosphamide, and dexamethasone, 3-drug versus 2-drug. And Rashid Baz from Moffitt Cancer Center reported that patients who were randomized to pomalidomide, cyclophosphamide, and dexamethasone had a better progression-free survival, and actually they felt that there was a improvement towards overall survival too. So when a patient with relapsed myeloma comes in, you're better off treating them with effective therapy, especially in elderly patients, because if you treat them with an ineffective therapy, then wait for relapse and then trying to apply a more effective therapy, sometimes the relapse is so bad they may not be in a position to go on and receive the appropriate therapy. So even in relapse situation, using the 3-drug combination turned out to be better. The Mayo Clinic dispensary reported that adding proteasome inhibitor, in this case bortezomib, to pomalidomide and dexamethasone gave better results. So they reported 3-drug combination was better. So the theme is emerging that if the patient has relapsed myeloma, you may want to consider optimum treatment rather than just choose anything like a 2-drug or something like that. So optimum treatment, 3-drug regimens seemingly coming out, again combining proteasome inhibitors, immunomodulatory molecules, steroid, etc. Now these are all clinical trials. What is not coming out is patient with renal impairment, patient with frail, elderly patient who did not participate in clinical trial. You got to remember, if you look at the overall NCI guideline and NIH, how many patients participate in clinical trial, typically 10 to 15% of the patients participate in clinical trial. So in a community setting, you have to keep in mind, it's not only the evidence-based medicine. The evidence-based medicine ends up being a guideline, but you have to apply to the patient how they come to you, their clinical situation, their prior treatment, whether they were progressing on last line of therapy, because all these Aspire trial, Eloquent trial, these patients were not progressing on lenalidomide or progressing on proteasome inhibitor in order to participate in that clinical trial. So all that has to be taken into account. So one recipe doesn't. We are happy that these trials allowed the approval of the FDA, so third-party coverage, etc., gets to be easier, but still at the bedside, at clinical, the oncologists in community still have to look at the patient and see how we can use this information and tailor the therapy to the patient's need. Next thing we again look at is how to manage the bone disease. There has not been a major breakthrough, but there has been a dramatic improvement in quality of life ever since bisphosphonate therapy has been introduced in the treatment of myeloma patient. The MRC9 trial from UK was the first one as a benchmark to show when a newly diagnosed myeloma patient, in this case zoledronic acid was used as opposed to clodronate or other medication they had used as a control, that using appropriate bisphosphonate therapy from newly diagnosed myeloma patient, especially those with lytic bone disease, it actually showed some improvement in the overall survival. That was the first trial. So using bisphosphonate therapy not only improves the quality of life, reducing skeletal related events, but those with a lot of lytic bone disease, it actually improved the overall survival too. So bisphosphonate therapy is an integral component. There is a large randomized trial with the denosumab, and we are all anxious to use it. But in my practice, if the patient has renal impairment, significant renal impairment, I know zoledronic acid and pamidronate could be used. It does not necessarily add to the renal impairment per se, but I prefer using denosumab, and sometimes there is a difficulty in third-party coverage. I use it as Prolia, which is approved for patients with osteoporosis. So once every 6 months, I tend to use that in patients with significant renal impairment because I'm a little bit afraid that any incremental increase in the renal function deterioration is not to the advantage of the patient. So I also use denosumab, but I'm hoping that the denosumab will show positive results and it will get eventually approved for the use in multiple myeloma.